कितने बजे है स्टार्टिंग?
Good evening to all the highly respected dignitaries here present virtually on this dais, and happy November as well as festive season. 2.5 years back, this was an academic activity started by then office bearers Dr. Hemant Gangolia sir and Dr. Jay Bhandarkar on a doctor's day. The first episode was conducted by them, and then the journal journey became a routine. We also express our gratitude to Maharashtra IIP, who has taken this activity in their stride and running it successfully. The popularity of journal journey is growing along with the efforts taken by Maha IIPians and the office bearers to make it recognized as a MMC credit point activity. We are thankful to Dr. Ramakant Patil sir and Secretary General Dr. Amol Pawar for that. Now may I request enthusiastic Vice President of AHA, Dr. Swati Likhite, to take over.
Thank you so much, madam, for the kind words. Good evening, one and all. Once again, myself, Dr. Swati Likhite, co-moderator for today's journal journey. Just 15 days back, we had a fabulous conference, MahaPedicon 2023 at Mumbai, having broad spectrum, very much thought-provoking topics with excellent speakers, and it was indeed we had a great academic feast. So, moving towards our today's journal journey, we have two important topics for discussion. First is development of clinical-based scoring system to diagnose TBM in children and hearing assessment in infants, children, and adolescents. Recommendations beyond neonatal screening. For this, we have two excellent speakers and experts, and our very own Dr. Uday Bodhankar sir as our today's guest of honor. And I'm sure the discussion and presentations are going to be really awesome. Before I start, I would like to welcome Dr. Neha Singh, Maha IIP Women's Committee co-chair person. So now I request our dynamic and respected Maha IIP President, Dr. Ramakant Patil sir, to give his welcome address. Over to sir.
Thank you, Dr. Swati. Distinguished and honorable guest of honor, Dr. Uday Bodhankar sir, pranam. My friend and who has got special affinity and love for Maha IIP and Maharashtra, because Pune is the PG alma mater. He has done his post-graduation from Pune KM Hospital, and we are students of Dr. Anand Pandit sir. And he has graduated and migrated further in ladders of academic success. My friend, Dr. N.K. Subramaniam, to whom we call with affection Subbu, are another homegrown audiologist, a senior audiologist, on very sincere and academically oriented, Dr. Rahul Vaidya, who hails from Nasik. And we have got nearly last for 20-25 years bonding for neonatal screening, hearing screening, and other things. We all know, we are all eager and all ears to listen what additional light probably this clinical scoring is going to suggest about diagnosis of tuberculous meningitis. Because the classical teaching and whatever statutory programs of NTEP will again suggest that we have to have microbiological isolation before calling it as a tuberculous meningitis. But probably this might be in case if it is not microbiological isolation is not possible. In that case, probably the scoring system will help us. And most important that Dr. Priyanka will probably decode about whatever hearing assessment from pure tone audiometry to OAE to BERA and different sorts of, this is all Greek and Latin to us even after 33 years of practice. And probably we might have a newer insight into it. And Anup is going to tell us about the clinical scoring in tubercular meningitis. I will like to particularly congratulate and put on record the thanks to the three people who are relentlessly working for this journal journey. Even if torchbearers were Dr. Hemant and Dr. Jay Bhandarkar, but it has been continuously possible every month after month without fail by because of efforts of Dr. Neeman Mohanty sir. He is a teacher to the core who takes everything from the presenters and guides them, and ably supported, and really other infrastructure efforts and this thing logistics is being done by Dr. Chitra Kulkarni and Dr. Neha Singh. And I will like to congratulate Dr. Vikas and Dr. Ajay Koli for their wonderful continuous efforts in academic activities. Along with MahaIP, they are doing these activities plus in addition to their own academic activities. And young, dynamic, enthusiastic AHA president with clear diction, Dr. Swati Likhte. It is a really wonderful team. MahaIP is having cherry on the top. It is the efforts of Raigad IIP. And we had one more program in the fold of MahaIP. We are every month having nearly 6 to 7 programs from Subspecialty Connect, Journal Journey, Case Challenge, then Immunization Dialogue, then Mahakatta. These all programs are going on, and this journal journey is possible because of Raigad IIP. And I really sincerely express my gratitude, and I really will express my gratitude to Uday Bodhankar sir, who has spared his time for joining us as a guest of honor. And I welcome my friend Dr. Rahul Vaidya also and Dr. Subbu. Over to you, Dr. Swati.
Thank you so much, sir, for your blessings, and your words are always inspiring all the young pediatricians like us. Proceeding further, I invite Dr. Mohan Warke, sir, Treasurer of MahaIP, to welcome and introduce our today's guest of honor, respected Dr. Uday Bodhankar, sir. Over to you, Dr. Mohan, sir.
Good evening, seniors and colleagues. Myself, Dr. Mohan Warke, Treasurer of Maharashtra IIP. It's my pleasure to introduce and welcome our guest of honor, Dr. Uday Bodhankar, sir. Actually, sir doesn't need any introduction, but still briefly I will introduce sir. Sir is former president of Central IIP. He is executive director at ComHead UK. He is deputy chairperson at CHPA UK. He is international council member of ISPR Japan. He is adjunct associate professor of pediatrics at Sydney University. He is nodal officer for RCPCH DCH UK. He is former honorable professor of pediatrics at IGMC Nagpur. He is honorable professor of IMA India. He is also former standing committee member of IPA. He is also former member of Advisory Council of Government of India. Welcome, sir, for this event. Over to you, Swati ma'am.
Thank you, Dr. Mohan. Now I invite our very own Raigad IIP President, Dr. Vikas More, to welcome the dignitaries.
Thank you, madam. I am Dr. Vikas More, President IIP Raigad. First of all, I am so grateful for Dr. Uday Bodhankar sir that he agreed to join this very premium event for IIP Raigad, now adopted by MahaIP, and for their blessings. Uday Bodhankar sir, sharing a screen with Uday Bodhankar sir is just like sharing a screen with Amitabh Bachchan of IIP CIIP. So it was a dream come true for us. Then secondly, I welcome Dr. Ramakant Patil sir, who is like a mentor for us throughout his period. He has really guided us and always helped us, always blessed us all the time. And that's why we are able to do such kind of activities. And thirdly, I welcome Dr. N.K. Subramanian sir, one of the best speakers in India right now, best faculty. In any conference, his talk, we wait for his talks. And we are also so fortunate to have him today for this journal journey. And then Dr. Rahul Vaidya from Nasik, who has joined today as an expert for guiding us for the second case paper. Lastly, I also welcome Dr. Anup Moreskar from Kolhapur, who is a pediatric neurologist and sharing a very important case paper on scoring system. And lastly, I welcome Dr. Priyanka Parikh from SRCC and various places she works as a pediatric neurologist to be giving very important case paper on hearing assessment for the age beyond neonatal age. So these two papers are very important for day-to-day in a practice for counseling purpose. So please be tuned till the end. And lastly, as a IIP member, I am proud to say that IIP Raigad is about to finish 100% voting by tomorrow. So I request all the members to kindly vote as early as possible because the days are finishing. Thank you so much. Over to you, Dr. Sautalik.
Thank you so much, Dr. Vikas. And now we are really pleased to have with us Dr. Uday Bodhankar sir as guest of honor today. Sir, I request you to shower your blessings, sir.
Good evening. Namaskar to all of you. I would like to pay my regard to Dr. Ramakant Patil, the dynamic patient of MyIP, of course, Secretary Dr. Amal Pawar, and Treasurer Dr. Mohan Warke. Of course, I have been a regular listener and watching the activity of MyIP more than 2 to 3 years. My salutation to Dr. Hemant Gangolia and Dr. Bhandarkar, I think we are joined here, to starting a very useful and I will say the PG friendly, pediatric friendly subject. Like, yeah, you know, even as a PG, we used to get sometimes bored to read the journey. But I think you all have made such an impact that it has become very popular. You know, within 5-10 minutes, you have more than 100 people join here, and they don't get the place, and they have to go to YouTube. I think you have to increase your space more than 300. I'm really grateful to you, MyIP. Of course, my regard to Raigad IIP, which I have been observing activities, and Dr. Chitra Kulkarni, madam, Dr. Swati Likhite. I am also a regular follower of AHA. So, my regard to you both. And of course, Dr. Neha Singh, who is representing a women's wing of IIP, because I have been in touch with Dr. Swati Bahu and other people, Geeta Patil, everybody I know in AHA and women wing. So, my sincere gratitude to all of you for starting such an activity which has become practitioner friendly, I will say, because the academician, they have to do it maybe out of compulsion or out of their interest. But as a practicing pediatrician, usually we don't get much time and we don't get interested in reading journals. Because I get an Indian journal, I just keep it and I don't read for one year sometimes. When I want to reference, I read. So this is a very good activity. I must compliment MyIP all team, Raigad team also. And of course, my salutation to Dr. Subramanian sir, who has come here and very good friend of mine. He is a chairperson of National Respiratory Chapter. He has been to Nagpur many times. Dr. Rahul Vaidya, consultant in audiology from Nashik. And of course, we have got eminent speakers who are there. Dr. Anup Moreskar, neurologist from Kolhapur. I think I went for Command Conference, Kolhapur. Even I met him there. And Dr. Priyanka Parikh, who is a developmental pediatrician in Mumbai. I think I must have met somewhere. They are all known. And she is going to talk on hearing assessment, infant. I think both the topics which are near to any practicing pediatrician. So, thank to you, because developmental of clinical based scoring system to diagnose TBM in children is very much useful in practice day to day. Similarly, hearing assessment in infant, we are trying to make it compulsory with the help of government, MOU with IIP, NLF together. That as in foreign countries, no baby discharged without making assessment of hearing. But in India, it has not been compulsory. I think with Gandvadekar and now Basaraj coming, we'll try to make it. children and recommendation beyond skin. I think if we diagnose in newborn only, then we can take steps earlier by 3 to 6 months or 9 months further. I think with this, I will not take much time. My regard to IAP, other people who are there, like Dr. Ajay Koti, who was the secretary of IP Road, I will also my regard to him. So I think most of the people on the skin, I know personally because more than 32 years I have been watching as a patient in 92 to now. And kindly see, again, it is off the record that kindly see to it that you do 100% voting. Of course, to to whom, to Nagpur person who is standing for patient, Vasan, and all EBM who are here. So my regard to you. Thank you, Chitra. Thank you, Swati madam. Thank you very much.
Thank you so much, sir, for your encouraging words and sharing your thoughts. Moving ahead, I also welcome our MMC observer today who is present for the journal journey. Now I invite coordinator Dr. Jay Bhandarkar, sir, to introduce our first expert for the day, Dr. N.K. Subramanian, sir, who is the chairperson of National Respiratory Chapter, CIAP Bangalore, and then introduce our first speaker, Dr. Anup Moruskar. Over to Dr. Jay.
Good evening, all dignitaries on the dais, off the dais, and thanks Swati, Neha, for remembering me. Though I was the first presenter and starter of this journey journal, and many thanks to first Chitra madam and Mohanty sir for continuing this process. So I found very privileged and I can say to introduce our expert, Dr. Subramanian sir. Actually, he doesn't require any introduction as such. But as a formality, I will do it. He is a professor of pediatrics and chairperson of IIP National Respiratory Chapter, past secretary of National Respiratory Chapter, the executive body member of 2012 and 20. And he has done a wonderful job in various posts in IIP, faculty in many modules, CME, conferences, excellent orator, many awards, books, and publications with his name. So, welcome, sir. Thank you for joining today. And our first presenter is Dr. Anup Moruskar, young dynamic pediatrician from Bharati Hospital, Sangli, and is a fellowship in pediatric neurology and epilepsy from Mumbai, and is working as a consultant pediatric neurologist at the Adi Child Neurology Clinic, Kolhapur. And at present, he is the assistant professor at PMC Islampur. Welcome, Dr. Anup, and again I welcome them and hand over to Dr. Swati for further proceedings. Thank you.
Dr. Anu, you can start your presentation.
Yes, ma'am. Okay. Is it visible, ma'am?
Yeah. Yes.
Yes.
So I'd like to express my sincere thanks to everyone for granting me the opportunity to present the journal on this platform. The article we'll be discussing is development of a clinical-based scoring system to diagnose tuberculous meningitis in children, authored by Setyo Handrastitu and Danning Latifa. This article is published in Archives of Disease in Childhood. Is an international pediatric journal from BMJ and RCPCH, publishing the latest research in pediatrics and child health, with an impact factor of 5.2 and site score is 5.7. So the tuberculous meningitis accounts for around 1 to 2% of all active tuberculosis cases globally. And this is a very severe form of tuberculosis, resulting in a high morbidity and mortality in the children. So fast, sensitive, and affordable tools to diagnose the tuberculous meningitis are not available. So in many clinical trials of TBM therapy, varied methods are used. The gold standard for diagnosing TBM is based on the culture of Mycobacterium tuberculosis from the CSF. To diagnose TBM, various scoring systems such as Thwaites, Lancet consensus, and modified Kenneth-Jones scoring criteria have been developed in several studies. But these scoring system necessitates advanced examinations such as CSF analysis, culture, and brain imaging. So aim of this study is to establishing a scoring system based on clinical symptoms and straightforward examination. This system can be utilized in underserved areas lacking advanced laboratory facilities for a quicker TBM diagnosis. So it conducted a retrospective study using a multivariable prediction model approach. The inclusion criteria encompasses pediatric patients aged 3 months to 18 years who were hospitalized with a diagnosis of either TBM or non-TBM based on multiple factors, including history, physical examination, blood work, chest X-ray imaging, CSF analysis, and head CT or MRI examinations. Exclusion criteria applied to patients with congenital hydrocephalus, leg paresis caused by hypokalemia, as well as those with other brain parenchymal lesions like tumor vascular malformations, intracranial hemorrhage, or a history of trauma. So the subjects were recruited at a national tertiary hospital spanning from July 1st, 2011 to October 30, 2021. It recorded demographic information, illness symptoms, and neurological examination findings from a patient's medical record. Laboratory data, which included a complete blood count, electrolyte level, ESR, and chest radiography, are extracted from the medical records. On the other hand, the diagnostic standard for the subjects were determined through CSF analysis, Gram stain and culture, as well as contrasting CT scan or MRI. The variable used to differentiate between TBM and non-TBM cases include the duration of prodromal illness, systemic TB symptoms such as prolonged fever, recurrent or chronic cough, anorexia, weight loss, then vomiting, headache, seizure, contact with adult TB patient, BCG and vaccination status, immunocompromised status, altered consciousness, bulging fontanelle, presence of meningeal signs, cranial nerve palsy, hemiparesis, involuntary movements, hyponatremia, and the detection of pulmonary TB finding in chest X-ray. It's worth noting that these 16 variables were sourced from various published studies. So, in this study, a total 229 patients were diagnosed with meningitis. Some subjects were excluded from various reasons, with having an inappropriate final diagnosis or lacking complete medical record. To determine TBM from head CT scan, it is considered the presence of basal meningeal enhancement or hydrocephalus as a criteria. Since not all patients underwent regular TB culture from CSF samples, it was used low CSF glucose or low CSF to serum glucose ratio, along with the predominant presence of mononuclear cells in the CSF as a criteria for determining TBM. The study recorded a total of 16 clinical variables obtained from the patient's history and physical examination. So, in the bivariate analysis of a symptoms variables based on patient's history, it was observed that TB systemic symptoms, a prodromal duration of more or equal to 10 days, having a history of TB contact and absence of BCG vaccination were the variables associated with the occurrence of TBM with a p-value less than 0.05. Simultaneously, the bivariate analysis of physical examination variables revealed that the low GCS score, presence of positive meningeal signs, cranial nerve palsy, and hemiparesis were all related to the occurrence of TBM with a p-value of less than 0.05. According to bivariate analysis, leukocytosis and hyponatremia were found to be variables associated with TBM occurrence with p-value less than 0.05. Additionally, the diagnostic examination of chest X-ray demonstrates significance of TBM, showing an odds ratio of 31.9 with a p-value of less than 0.001. In the multivariate in a multivariate analysis, all variables with a p-value less than 0.25 from symptoms, signs, and workup examination were chosen to derive the final score, and internal validation was performed. The significant variables, which included a prodromal illness duration of more or equal to 10 days, systemic TB symptoms, the presence of TB contact, and the detection of pulmonary TB on chest X-ray findings, with a p-value less than 0.05, formed the systemic components. Meanwhile, the neurological part, the final variables comprised a GCS score of less than or equal to 12, a positive meningeal signs, cranial nerve palsy, and hemiparesis. In this study, the AUC curve was employed to evaluate the discriminative ability and identify the probability intersection of the total score for assessing the quality of a final model scoring system. Upon analysis, it was determined that a cutoff point of more or equal to 3 for the total systemic scoring parameter yielded sensitivity and specificity values of 78.8% and 86.6% respectively. The AUC value for the total systemic score as a diagnostic predictor of TBM was 0.89. The p-value of less than 0.001 as illustrated in this figure. Similarly, for the neurological scoring parameters, a cutoff point of more or equal to 2 resulted in sensitivity and specificity values of 62.2 and 75.2 respectively. The AUC value for the total neurological score as a diagnostic predictor of TBM was 0.73 with a p-value of less than 0.001 as demonstrated in this figure. Hence, the final model of the scoring system can be seen in this table with the systemic and neurological components. The subject's systemic and neurological scores both met the minimum total score requirements of more or equal to 3 and more or equal to 2 respectively. As the result, the system demonstrated a sensitivity of 47.1%, specificity, and 95.1%, a specificity of 95.1%, a positive predictive value of 90.9%, and negative predictive value of 63.4%. This finding indicated a low sensitivity but exceptionally high specificity. The study demonstrated the ability of a newly proposed scoring system to predict TBM diagnosis in children. In terms of subject characteristic, the age group of children under 5 years and of old constituted the largest group with 109 patients, whereas those aged over 12 years represented the smallest group with only 26 patients. It's worth noting that these findings were consistent with other studies conducted by Dodd et al. And Daniel et al., which also identify children under 5 years old as being particularly vulnerable to meningitis. Following the multivariate analysis, the final model of the scoring system underwent validation using the bootstrapping method. This validation process was divided into 2 components. First is systemic and the second is neurological. 2 scoring systems are notable in this context. The first, developed by Marais et al., is referred to as the uniform case definition. This system considered not only clinical manifestations of symptoms and signs, but also incorporates advanced workup examinations such as CSF criteria obtained from a lumbar puncture and head imaging criteria in the form of contrast CT or MRI, as well as CT, MRI, ultrasound evidence for the TB outside the CNS. The second scoring system introduced by Thwaites et al. Is specifically designed to differentiate between TBM and bacterial meningitis. It comprises clinical manifestation, symptoms, and signs along with components of CSF analysis workup without any necessity of head imaging. Numerous studies have created scoring system aimed at identifying the managing TBM in children. Anwar et al. Utilized the MKJSC criteria for diagnosing pulmonary TB in children. Despite achieving sensitivity and specificity of 93.6% and 88.6% respectively, MKJSC criteria lacked the inclusion of neurological parameters related to TBM. Another study conducted by Lee et al. Designed to differentiate between TBM and viral meningitis, established a weighted scoring system. This system incorporated predictive factors such as hyponatremia, CSF dehydrogenase more than 70, CSF protein more than 160, cranial palsy, voiding difficulty, and convulsions. Then Seto et al. Developed a novel TBM acute neurological scoring system. This system predicted severe neurological sequelae using weighted score on the variable without proceeding to univariate and multivariate analysis, thereby introducing the potential for observer bias in assessing the quality of variables. To utilize the scoring system, it devised its necessity to meet the minimum total score of more or equal to 3 for systemic and more or equal to 2 for neurological components separately. The overall total score was deliberately not utilized to avoid potential bias if the total score was solely reached through one part, be it systemic or neurological. It's important to note that the lower sensitivity observed in this study could pose a challenge when applying this system to a larger population. However, due to its high specificity, patient meeting the criteria were expected to commence TBM treatment promptly. So, then a patient can be directed to more advanced healthcare facilities for further confirmation of their TBM diagnosis, all the while continuing their treatment. The limitations are limitations of the study. It is important to note that routine CSF culture for the detection of Mycobacterium tuberculosis was not conducted in all cases with a working diagnosis of TBM. Consequently, a comparison between the gold standard and the newly constructed scoring system couldn't be made. Additionally, it's crucial to acknowledge that this study adopted a retrospective design, introducing the potential for bias in the accuracy of recorded medical record and the likelihood of underreported clinical features. Further analysis is warranted, specifically using the microbiological gold standard derived from CSF sample to distinguish between TBM and non-TBM, preferably employing a larger sample size and a prospective study design. This approach is necessary to enhance the statistical power and reliability of the scoring system. So the conclusion, the scoring system with a sensitivity of 47.1% and specificity of 95.1% can effectively predict the diagnosis of TBM in children. It utilizes a cutoff point score of more or equal to 3 for a systemic and more or equal to 2 for neurological components. Furthermore, this user-friendly and straightforward scoring system may prove valuable in setting where laboratory resources are limited. So, this study contributes a straightforward diagnostic tool for identifying TBM in children, relying on basic and uncomplicated examination as its parameters. As a result, the developed scoring system holds promise for utility in resource-constrained settings, particularly in developing countries where laboratory resources may be scarce. So, this study affects in additional research aimed at optimizing the scoring system developed in this study could involve a comparison with a culture or expert MTB of CSF using a larger sample. The use of this scoring system, which emphasize comprehensive patient history and thorough examination, particularly regarding neurological signs, may facilitate earlier TBM diagnosis by clinical practitioner, potentially reducing mortality and morbidity. This study has the potential to advocate for government initiatives to provide the diagnosis of childhood TBM in rural or remote areas. Thank you.
Thank you, Dr. Anu. It was an excellent presentation, very informative and thought-provoking. Now we are all eager to listen to the comments by our expert, Dr. Subramanian sir. So over to you, sir.
Yeah, I should first congratulate Dr. Anu. You have made a wonderful presentation. The point was that should we or should we not use a scoring system? First, let me come to a point. Let's not get into the article first, but my comments would be in the form of do we have got any advantages of using various scoring systems? I will take away the practitioners from the areas like when we have used Jones criteria for diagnosis of rheumatic fever, Center's criteria for diagnosis of streptococcal sore throat. We have so many scoring systems. How far the scoring systems have helped us? There is a criticism about it. The first point. The advantage of a scoring system is that it will give objectivity. You know, some patients may say, some pediatricians may say, yeah, it has got weight loss and fever. To me, it is tuberculosis. And somebody say, no. Whenever you get itching in the manto, it is more likely to be TB than otherwise. Somebody says that this X-ray finding, I'll bet on this. It is same as your, you know, how you play games in your IPL matches or on online games. So it is a head or tail situation that you would get into it. The second advantage of a scoring system is that it gives a holistic and comprehensive approach to a disease, which we accept that point. Because in the checklist, there is a weightage given to each score and there is a sum total that comes out. So it is very difficult to compute ourselves in our mind any of these scoring parameters, and therefore it takes away some amount of bias. Let's agree on this point. And it makes up for lack of evidence, which is difficult in circumstances like tubercular meningitis. There's always a difficulty in getting the evidence, like culture, etc. And therefore, you know, it takes away our effort and maybe helps us to get an indirect evidence. There are disadvantages of scoring system like this. One is it gives rise to some kind of oversimplification. Do you agree? If your TBM is very easy, you take out that scoring system, have a printout on your table, make a tick and give the score, you know, and then you are done with it. It may not weigh the parameters in any of the study with a kind of weightage. Although I give the score 1, 2, less than 1, more than 1, minus 1, etc. in any scoring system, it may not weigh each parameter to its merits. These are my comments as far as any scoring system is concerned. And therefore, we don't have an ideal scoring system. They start searching a scoring system for a developing country, developed country, this country, that country, so on and so forth. And TBM doesn't see any country for that matter. TBM is a TBM. So therefore, this is my criticism on scoring. Number 2, let's come to diagnosis of tuberculosis. I want somebody on the chat box to be very active. Chitra, please take care of the opinions. Please type in the chat box. How many of you feel that tuberculosis is a disease? Yes or no? TB is a disease. Please type yes or no. I will watch the chat box. I'm just looking at the chat box. I wanted to just see TB as a disease. Yes. Many are typing. Okay. Many have written yes. Okay. Now I will ask the next question. Is TB a problem or a disease? Those of you will tell that TB is a problem, not just a disease. Please type yes. TB is a problem, but not just a disease. Anybody know for this? There is nobody know. Why it is a problem? It is because we went on indirect means of chest X-ray, Manto, and scoring system in the past for diagnosis of pulmonary TB, and we have done away with that. So therefore, it's no longer a disease but a problem. Okay. This is where we are as far as tuberculosis is concerned. Because it is a problem, and what is the problem? The problem is that of MDR TB. Now, my next question to all the audience, so that you will become clear on concepts related to tuberculosis. Can we distinguish MDR tuberculosis from non-MDR tuberculosis clinically? Yes or no? Can we clinically differentiate an MDR TB from non-MDR TB? We can't differentiate. That's the crux of the matter. Now, if you take at the load of tuberculosis, it is 1 to 2% is tubercular meningitis, and largely it is pulmonary, and least is extrapulmonary. But this ratio of pulmonary to extrapulmonary varies with age. Like, are we talking of overall tuberculosis or tuberculosis in infancy, in less than 5 years, in adolescent, so on and so forth. Based on that, anyway, the ratio of pulmonary to extrapulmonary varies. Now, is it possible to diagnose tuberculosis microbiologically? Yes or no? We can do yes. There is no need to type. Is CSF sample a good source for gene expert? Please type yes or no. This is again important for us. Is CSF sample a good sample? And Anup, you being the neurologist, one comment from you in between for CSF, CBNAT studies, gene expert. One line from you, now that you have presented. Anup bhai, can you unmute? One line from you.
Yes, sir.
Can it be useful or not useful?
I think it can be useful.
It can be useful. Okay, fine. He says it is useful, but yield is less. Now let me come to the point. Now, in a patient with tubercular meningitis, if I take aggressive samples from the chest or respiratory tract, can I get CBNAT positivity? This is a question. If I'm very aggressive on pulmonary TB in an extrapulmonary TB like. So now my questions were little away from the scoring system. The only point is that today we are having only CBNAT with us with a bit of sensitivity of close to 90%, etc., with poor yield from the CSF and the pleural fluid, ascitic fluid, so on and so forth. But don't you think that in days to come, this question please answer. Is the scoring system going to be there or is going to go away with time? Type yes or no. It's going to go away, yes or no? It's going to go away. So it's a question of time. So it is the question of the next journal club. That's all. So this speaks volumes about what we should do. Okay. Now, in 2023, in the current context, when a child is having tubercular meningitis, can I wait and watch till I get a microbiological diagnosis? Please type yes or no. Now I am putting you into a fix. Can you wait and watch? The answer is no, isn't it? Therefore, somewhere I have to have an exceptionally good and a sharp clinical evaluation for a clinical diagnosis of tuberculosis in an adverse situation where I can't do a microbiological diagnosis. That's exactly where we are as far as tubercular meningitis is considered. And that's the problem. Now, therefore, given the load, we are fine with the diagnosis of tubercular meningitis by given the score. Now, my question to a neurologist like Dr. Anu, what will you do if a child doesn't respond to antitubercular drugs in a TBM? What will you do? Now, will you add second line drugs or will you now look for evidence? Now, this is a difficult question. I don't want you to be in fix because a very difficult question to answer. Only Smile can answer. Now, therefore, if you are sure that you are going to hit a sixer or will you be caught at the boundary line, that only whether it is Wankhede pitch or Lucknow pitch, it is going to tell us. It is not going to be decided by strength of the bat, bowler, timing, the batsman. Do you agree? When you start off with a sixer, you will never know whether you will actually cross the boundary line. This is the problem that we are having as far as tuberculosis is concerned. As long as you think tuberculosis is a disease, then you are correct in going for scoring system. The moment you think tuberculosis is a problem, then you cannot go for scoring system. You need the evidence. Now, in those circumstances where you are pushed to early diagnosis of tubercular meningitis, and if you think you have time, please invest your energy in trying to get the bug microorganism from other specimens, more valued specimens. Maybe you can even do bronchoscopy and get a ball and try for a better specimen for trying to see if there is. See, it's a disseminated tuberculosis. I do agree it is not parenchymal tuberculosis. Very difficult to get a ball specimen also. But an excellent article from Dr. Cabra showed that even in extrapulmonary tuberculosis, 1/4 of them, or even as high as 15 to 20% of them, may have a coexisting pulmonary tuberculosis. So therefore, we should not leave the opportunity of trying to get a bug which is related to that. Now, coming back to this particular scoring system, it has a sensitivity of 47% and specificity of 95%. That means to say the scoring system is very useful in excluding tubercular meningitis and not including tubercular meningitis. Do you agree? If sensitivity is low and specificity is high, that means it helps us to exclude tubercular meningitis. And what will you do after excluding tubercular meningitis? You have to look at other possibilities for the presentation of a meningitis-like picture, which we popularly call as acute encephalitis syndrome. Now, are the features, any of the features in the scoring system, are they specific or non-specific to tuberculosis? They are all specific to meningitis and raised intracranial features. You can take, for that matter, headache, hydrocephalus, cranial nerve palsy, so on and so forth. They will all talk about the probability of an increased intracranial infection. The pattern of raised intracranial infection fits in with the clinical prototype textbook description of tubercular meningitis that we have learned. So basically, we are doing matching with textbook descriptions versus the presentation that we are having by using the scoring system. This is simple maths, like match and find out what scores we have got. And I will leave it to the wise audience. Now, the question is, can we have a parental X-rays being taken, parental specimens being taken, close contacts being served, being evaluated for being aggressive in trying to get? If somebody is having tubercular meningitis in infancy, is it possible that somebody in the family will be having tubercular meningitis? Or is it that somebody beyond 40 kilometers will have a tubercular disease? It is very much possible that there will be close contact and some evidence of tuberculosis. The problem comes when there is telltale evidence of tuberculosis in the family history. Somebody was given ATT, sir, we don't know what to do. That's happened to a pediatrician in clinical practice. What I will do, I will just wash off my hands, refer and relax and have a nice dinner rather than trying to break my head, because very, very difficult to answer to those mothers. Later, if they end up, I will have to only send to Anup because they may have persisting seizures, continued raised ICP features, and a neurologist is all that we can seek for some help in these helpless mothers. And given that the long-term outcomes of a disease may or may not be good. And I also have a problem of simultaneously starting steroids in a patient with not just empirical ATT, but poor prescription of steroids. And what if I give steroids in a patient with a drug resistant or a multi-drug resistant bacilli? These are my difficulties as far as I'm concerned. Okay, if I have confused you, don't worry. In the absence of robust microbiological evidence, with a good effort, the least that you can do is go for a scoring system. And if I'm an expert and if I don't give you any conclusion, then you will say, Subbu, you are a very good orator, but you have not solved my problem with regard to tubercular meningitis. Do you agree? Therefore, I always say, when the ideal is not possible, what is the next one? The next one is inferior alternative, but an available alternative, that is scoring system. I think I have placed in your mind the way in which you can approach tuberculosis and tuberculosis extrapulmonary and meningitis in particular, how you can approach. And I will reserve my comments, if at all, if there is any other discussion that comes in, I may unmute and come in. Dr. Chaitra and Swati and Dr. Uday Bodhankar sir, please give me some opportunity, because some thoughts may again come on the way while it's a journey. Tuberculosis is one disease. All of you please type now, is tuberculosis overdiagnosed? Yes or no? Okay, I see yes. Okay. Is tuberculosis underdiagnosed? That's also yes. So therefore, how to appropriately diagnose tuberculosis? That's the problem. The problem is that we wanted an organism to be diagnosed by clinical features. The organism has to be isolated and proved. Organism cannot be drawn from clinical features. I will close my remarks by telling a small joke, which I enjoyed, but I might not have shared in the previous conferences. One of my colleague professor told me, by looking at the face of somebody, I will tell whether he has got TB or not TB. Look at the way and confidence. If I see somebody's face, so if in a Zoom meeting, if I see, I will tell who are all tuberculosis, who are all not tuberculosis. Can you imagine? I was wondering, and somebody asked me, Subbu, what is your remark on that professor who told I can diagnose tuberculosis by seeing the face? I told only one line. I don't like a professor who wait for tuberculosis to come up to the face.
Yes.
Well, you should not wait for a face to speak about tuberculosis. You should diagnose it pretty early. Now, the challenge of diagnosing early tuberculosis is when the scoring system also won't help us, because scoring system largely depends on available and visible clinical evidences, like, if not face, something else for us. And therefore, the challenge and drawback would be that you will not be able to make early diagnosis. You will always be able to make an appropriate clinical diagnosis probably late in the course of the disease, and that's why the sensitivity is less. If the sensitivity of a scoring system is high, then you can make early diagnosis, because there will be large pool of patients who fit into the scoring system. If the specificity is high, that means to say it is always late diagnosis of tuberculosis with scoring system. These are my remarks, and I would invite discussion from others. Even I am eager to know what is the best score. Okay, you can score me as well in the on a lighter vein in the chat box, 1 to 5. Whether my comments on tuberculosis was okay or not okay. I will give 0 to 5 for you, and I'll be just happily seeing the the chat box.
Thank you so much, sir. Thank you so much, sir, for your enlightening thoughts and sharing your experiences on the article. And I guess sir has really simplified the subject for all of us. Moving over to the next topic, may I now invite our IGAD IIP President, Dr. Vikas More, sir, for introducing our second expert, Dr. Rahul Vaidya, sir, who is a speech therapist at Nashik, and also to introduce our second speaker of the evening, Dr. Priyanka Parikh. Over to you, sir.
Thank you, sorry, madam, for giving me the opportunity. First of all, I welcome Mr. Rahul Hemant Vaidya. He is a very senior speech therapist from Nashik. He has a vast experience of more than 18 years in the field of speech therapy, more than 21 years. He worked as a lecturer for 10 years at DSC HI and DSC MR. He has more than 15 years of audiologist experience at HAL Hospital at Ozer. Right now, he is running a firm called as Samvad Speech and Hearing Clinic, available at Nasik. He is a professionally freelancing consultant. As Ramakant Patil sir told that he is a very academically oriented speech therapist. So he has his own insights from his vast professional experience, and it will be really useful for all of us. He has received special training in Australia for advanced technologies in cochlear implants, twice till now. And he has worked for 3 years in MVP Medical College, Nasik, as an audiologist, and 2 years worked with Military Hospital as an hearing aid dispenser. And thank you, sir, for being available to us as an expert. And then we are having Dr. Priyanka Paharik, who will be reading a very important case paper. She is practicing as a developmental pediatrician, having attachment with NHSRC Children's Hospital, Saifi Hospital, by Asha Child Development Center, Cloud9 Hospital, and also a past honorary at BJ Wadia Children's Hospital. Her areas of expertise are autism, attention deficit hyperactivity disorder, learning disabilities, slow learners, developmental delay, cerebral palsy, and the syndromes like Down syndrome. She has a training experience as a clinical fellow at Pediatric Neurodisability Clinic, Northwick Park Hospital, London, and worked as a consultant at Learning Disability Clinic at Sion Hospital. She has ranked second in MD Pediatric and received gold medal in FCPS examinations. And she has various presentations in various conferences, in the journals and textbooks. And over to you, Swati Madam, for the proceedings.
Thank you, sir. May I request Dr. Priyanka to start her presentation?
Hello, good evening, everyone. Am I audible and is the
Yes,
screen
yes.
visible?
Yeah.
Yeah, thank you
Yes.
so much, Dr. Vikas More, sir, and Dr. Chitra and everybody in the group for the invitation today and for the kind introduction. I will be today in the session on journal journey. I will be presenting on the article Hearing Assessment in Infants, Children and Adolescents, Recommendations Beyond the Neonatal Screening. So it's a clinical report published by the American Academy of Pediatrics in the journal Pediatrics.
Ma'am, you use your mic. You are not audible
Yes,
properly. Yeah.
Am
Please
I
use.
audible right now?
Yeah. Yes. Yes.
Yes. Yeah, so I'll be presenting on the journal article Hearing Assessment in Infants, Children and Adolescents, Recommendations Beyond the Neonatal Screening, published in the journal Pediatrics, which has an impact factor of 8 in the August 2023 edition. So as we all know, the children who are deaf or hard of hearing are at high risk for deficits in their language acquisition during the very important neuro-linguistic critical period, the first 5 years, which has its subsequent impacts on the sequential memory, abstract thinking, executive functions. It also leads to poor academic performance, difficulties with personal social adjustments, as well as emotional difficulties. So how do we prevent or reduce these adverse consequences? So one is through the identification through the newborn hearing screening programs and subsequent timely early interventions. So the hearing screening programs identify about 1 to 3 per 1,000 born with the atypical hearing thresholds. However, a small but significant number of children will become deaf or hard of hearing after birth. So this actually accounts to another 1 to 3 per 1,000, and these are due to conditions that manifest with a delayed change in the hearing levels or due to acquired causes. So it is very important to have an ongoing surveillance for changes in hearing thresholds even after infancy. So what does this report highlight? This report covers hearing assessment beyond the newborn period. It reviews risk factors for hearing level changes, and it describes an ongoing risk assessment for which involves subjective evaluations to pick up signs for atypical hearing based on milestones, physical examination between newborn period and age 4 years, as well as periodic objective technological based hearing screenings from 4 years to adolescence. And it is providing guidelines as well as recommendations for the pediatric primary care providers on the assessment and care of children who are deaf or hard of hearing. So what is their first recommendation? They say that all children should undergo a risk assessment for changes in hearing thresholds by utilizing objective and evidence-based risk factors for delayed onset hearing changes. So one should look for utilize initial newborn well visits in the first month to look for these risk factors, to review hearing screening results, and also discuss these factors with parents. And in a child who comes later at an older age in the OPD setting, one should review the risk factors at a later visit. And all children, regardless of risk factors, should also have their hearing screened in accord with their current Bright Futures AAP recommendations for the preventive pediatric health care. So the risk factors are grouped as per etiology. So if we have a family history, it points towards genetic causes, which increase the probability despite a negative newborn screen because it may present beyond the newborn period. Looking at the perinatal history of HIE, ECMO, an ICU stay of more than 5 days, or hyperbilirubinemia needing exchange transfusion is a risk factor. Congenital CMV is one of the most important causes of childhood sensory neural hearing change, and it accounts for about 25% of children who are deaf or hard of hearing at age 4. So usually this is asymptomatic at birth in 90% of the newborns. And it is also usually associated with a negative newborn screen. So we really should not miss them by just looking at the newborn screen. Looking at other infections, meningitis, otitis media, as well as Zika infections, any history of trauma, exposure to damaging noise levels, as well as ototoxic drugs. So the Joint Committee on Infant Hearing Position statement has listed the risk factors for the hearing losses and guidelines for infants who have passed newborn hearing screen. So for example, if a newborn has had a history of ECMO or there is history of CMV, the diagnostic recommended diagnostic follow-up should not be later than 3 months and should be monitored every 12 monthly. Or if you see any craniofacial malformations or ear dysplasia or a white forelock, the recommended diagnostic follow-up should not be beyond 9 months and it should be monitored. So the risk assessment does not stop just at risk factor identification, but it goes beyond to doing actual real-time evaluations at the visits. So we have to do developmental screening of language as well as communication milestones and looking whether the child is developing normal language skills. So that shows us that the hearing is, probably normal. Questioning caregivers regarding concerns about hearing, looking at any recent medical histories to assess for any newly acquired risks of trauma or noise or infections, and doing a physical examination with a background knowledge of the potential risk factors. So if we see a malformed ear canal or auricle or heterochromia of the iris or cleft lip or palate, any acute otitis media or otitis media with effusions, these are all risk factors. As per their second recommendation, children at all ages should have prompt objective hearing screening if there is clinical concern or caregiver concern of permanent or ongoing hearing change. So it has been seen that caregiver concern is of greater predictive value than the informal behavioral examinations conducted in the clinical settings. And studies have shown that parents are as much as 12 months ahead of physicians in identifying a child's change in hearing status. Hence, even if there is a negative screen, but if there is an ongoing caregiver concern that the caregiver is really concerned, no, doctor, there's something wrong, it should prompt immediate referral to audiology for a comprehensive evaluation of hearing. And there are different tools which are used for objective hearing screening. So for the middle ear, for all ages, one should do tympanometry. For the inner ear, from birth to 6 months, it is automated ABR. For all ages, one can use the otoacoustic emissions to look for the outer hair cells in the cochlea. And from 4 years to older age groups, one uses the pure tone audiometry. So this table shows the different tools for the objective hearing screening as per the age and the advantages as well as limitations. As per recommendation 3, a child with a positive screen for atypical hearing thresholds in one or both ears should be referred to an audiologist for diagnostic consultation and testing. So the result is considered as a pass or the screen is negative when both ears show typical thresholds on the same day. So one should not resort to multiple screens to achieve a negative result or repeated screening of a single ear on different days. They do not constitute a bilateral pass or negative screen. And children whose screening tests suggest a unilateral or a mild hearing change should also be further evaluated. So one may think that, okay, 1 ear is normal, then, why do anything further? But even if there is a unilateral change, those children should also receive appropriate interventions and support. As per the 4th recommendation, behavioral audiometry may be impossible or inaccurate for some children, especially with developmental or behavioral concerns. And in this situation, referral to audiology for electrophysiological testing like ABR would be more appropriate. So when we do pure tone audiometry, it requires a child to follow directions. So the audiologist presents sounds of different frequencies and the child has to raise hand when listening to the sound and respond consistently to the sound stimuli for a reliable result. But 30 to 40% of children who are deaf or hard of hearing have co-occurring developmental conditions like autism, global delays, and they may not be able to comprehend instructions. They may not be able to cooperate with the testing. So in these children, it is important to just forego the screening test and refer directly to audiology for the ABR because that's performed in the sleeping state under sedation. It can assess the entire hearing pathway so that we are able to immediately start with the other therapeutic interventions like providing with hearing aids as well as the subsequent therapies. As per recommendation 5, newborn and childhood hearing screening results should be reviewed with families and documented to facilitate tracking and follow-up. So it's not about just doing the screens, but discussing with the family. And tracking is very important. Documentation is very important. So to establish office practices to ensure that there is appropriate surveillance, there is appropriate timely interventions and support. So they've suggested adding templates to the electronic medical records, which could include the risk factors and which would prompt the providers to perform and document the hearing screening as per schedule. One could have written protocols for the hearing screening and follow-ups. And in the US, the identification of children who are deaf or hard of hearing is reportable to the all state EHDA programs that they have for the state-wise public health surveillance as well as for the national tracking by the CDC. As per recommendation 6, which is like a follow-up from the recommendation 3, to prevent negative results and to avoid delays in identification and access to language and support, screening tests should not be repeated more than once before referral to audiology for consultation and further testing. So doing repeated screening may just delay the identification and the support that the child needs. It may even falsely rule out changes in hearing and it just adds unnecessary cost, which leads to the lack of follow-up and also subsequent failure of the comprehensive testing that we are looking at. And what is important is prompt action and support, which is important and required for the optimal development of communication as well as language skills and further academic, cognitive, and socio-emotional development. And here it's important, the role of the pediatric primary care provider is important in arranging and confirming follow-ups, testing, as well as the appropriate referrals. So as per the recommendation 7, If comprehensive audiologic evaluation identified the child as deaf or hard of hearing, it is important to discuss the importance of supporting the child's communication, language development, socio-emotional needs with the family, as well as with school settings. It is important to refer for early intervention specialized for these children and also to do the other medical specialty referrals. So there are various tools for acquiring spoken language. One can use cochlear implants, hearing aids to amplify the sound and to help with acquiring spoken language. One could use visual language like the American Sign Language. And in fact, what is more recommended is a bilingual language acquisition. So use of both signed as well as spoken language to corroborate each other and help with the eventual age-appropriate language development. There are some children who may have a post-lingual hearing change. So they've had a normal early childhood language development, but they have had some reason thereafter, later, maybe trauma. Such a child also needs accommodations in school. And specialty referrals are very important. It's a multidisciplinary management. So to look for associated genetic conditions, meeting a geneticist, importance of vision assessment to look for any associated visual issues, as well as vision is very important for these children because the main way of learning is vision and through visual aids. Assessing for other coexisting developmental conditions. So having a developmental pediatrician on board to look for autism, ADHD, global delays, learning disabilities, because these are seen in 1/3 of children to have coexisting developmental conditions. So let me speak a bit more on this slide. The report describes deaf families, culture, and lived experience. So what do we mean by this? And it says, culture and personal experiences influences the degree of medical intervention. So let's understand this better. So there are some parents or caregivers of children who are deaf or hard of hearing, who themselves are also deaf or hard of hearing. And this is a community which considers themselves as culturally deaf with a capital D. And this community values the American Sign Language and prefers, or in fact chooses to use the sign language over spoken language, and they may have a completely different perspective. So you have two groups, culturally deaf families as well as the deaf and hard of hearing adults. So they have their own experiences with hearing care specialists, their own experiences with special education system as well as hearing technologies, and they may have their own preferences. So it is very important to develop a rapport of trust and respect for their own lived experiences, expertise, their own cultural perspectives as well as preferences. It is essential to provide the medical home for their children. So the Americans with Disabilities Act requires that interpreters should be provided for caregivers and patients who may prefer or choose to communicate with medical personnel in American Sign Language, and these should be arranged in advance. So what new did we learn from this report? This clinical report replaces the 2009 clinical report, and the changes include updated information on the risk assessment, alignment with their Bright Futures, early hearing detection intervention, promoting EHDI implementation tip sheet, updated terminology, as well as considerations for providing a medical home for children who are deaf or hard of hearing. And also removal, most importantly, removal of the deficit framing terminology. So if you have noticed that, they have used terminologies like hard of hearing instead of using loss, hearing impairment, or failed. This is to reflect that children who are deaf or hard of hearing are equal, healthy, and whole. As we discussed in the previous slide, the capitalized term deaf with the capital D, it refers to the community of individuals who identify with the culture of deaf people. And this community has been actually historically created from the 18th, 19th centuries, and it is actively transmitted across generations. And this community believes in using the American Sign Language. And the terms deaf with a small d and hard of hearing are audiological designations. Terms deaf blind refer to individuals who have both vision and hearing impacts. So what are the take-home messages for us from this report? Because this is an AAP publication with their guidelines. Now, for us in India, IAP has published guidelines on newborn hearing screening, but we don't as yet have published guidelines beyond the newborn period. So this report helps with guidance on hearing screen and assessment beyond newborn period until adolescence. And these recommendations could also be implemented by us here in office practice for ongoing surveillance, early detection of hearing changes, as well as providing timely interventions so that we can promote optimal outcomes in language as well as academic and social emotional development for our children. Thank you.
Thank you so much, Dr. Priyanka, for the insightful presentation. It was a very excellent and with clear understanding, and all the 7 recommendations which were discussed would be really beneficial for all of the general pediatricians like us. And now we would like to hear comments from our expert, Dr. Rahul Vaidya sir. So over to you, sir.
Thank you, Maha IAP, and all the respected doctors, especially Dr. Ramakant Patil. And it was an excellent presentation regarding my a topic from my heart, which is neonatal hearing screening and beyond it, actually. So, till now, neonatal screening was known by most of the pediatricians. But since we are looking at further testing and further assessment and maybe a bit of management part of it also, uh, I would like to congratulate uh, all the committee members who have chosen this topic uh, and invited me for for my opinion. First of all, JCIH, Joint Committee of Infant Hearing, had recommended 136 rule. That was 1 month of screening, 3 months of diagnosis of hearing loss, and 6 months of management, that is hearing aid use, or further management, like maybe further intervention like speech and language therapy and auditory verbal therapy, and further maybe ahead of it, after say the child gets further good weight, and after 7 to 9 months for further cochlear implant if required. So now the same rule has been modified by JCIH to 1, 2, 3. So it will be very early that everywhere we are trying to do early identification management. So this is about neonatal screening. Second, and recommendation to parents and caregivers, uh, concern is also important. But many a times in India, what we have observed, like parents are aware that there is something wrong with my child, and the child is not speaking and the language is not developed, but they are not concerned about their hearing, or they somehow, because of the taboo or social thing, they avoid coming with a complaint of hearing loss. So many a times you may see in your OPD children coming with speech language delay, but they may finally found to have some mild or moderate kind of some small quantity of hearing loss, which may affect their articulation, pronunciation, then language development and speech, depending on the quantum. Second, even unilateral hearing losses affect. Unilateral hearing loss, the child may not have orientation and may miss some inputs from one side, like 90%, 90 degree of this cone, which is on the affected side, which is not heard, or even not, the child is not aware also. So he may miss some social interactions or some educational inputs. So that unilateral hearing loss should also be considered. That is one thing which I liked in the presentation, which was mentioned in the paper. And in case of children whose mental age is above 3 years, so the child with mental age above 3 years and if they can hold objects, we can condition them for putting down some toy, which is called a play audiometry. And some children who are not doing that, maybe below 3 years of mental age, and who have neck control, we can do their visual reinforcement audiometry, which is done in a soundproof room with a speaker and a light on it. And the light is given along with the speaker. So the child orients towards the speaker. The speaker means I'm saying about audio output speaker. And then as soon as the light, the sound comes, the child looks towards the light in anticipation that the light will be on. So in that way, we can diagnose behaviorally along with objective evaluation, which has been discussed here. So behavioral assessment can be done uh, with good sound treated room setup, which is available in most of the cities in Maharashtra now, because there are audiologists working around. So along with that, in BERA, like a brainstem evoke response audiometry, or ABR, which is most known test by pediatricians, and which we get maximum referral for diagnosis. There are different types of stimuli now used, which gives us better results, and the diagnosis becomes even faster. So uh, children who are not getting pass result in OAE, or even if they are getting pass in OAE, some of the children have OAE pass, but they have something called ANSD, that is auditory neural synchrony disorder. So ANSD is also frequent. It's quite common nowadays, and the diagnosis it's getting diagnosed very much. So even children with mild or moderate hearing loss also may have ANSD, which may affect their comprehension and discrimination of speech, which may lead to the quantity is not that much, but the effect of that hearing loss is too much. And then the child is lacking in all the developmental aspects further. Uh, there's one more point I would like to just put here. It's like we hear with our brain. So not only first after diagnosis, we should give them amplification or hearing aids, and if then further training has to be done. So the training is done by audiologist and speech language pathologist by means of two, three different approaches. One is called one is the type with a child having only hearing aid and have not having good benefit with hearing aid, and there is no chance to go for further management of cochlear implant. Then there is something called total communication approach. So in that, the child looks at the face and hears through the ear. That is with visual and auditory input. That is called total communication approach, which is used in deaf schools most of the time. And sign language. Sign language is where there is no chance. Like there is absent nerve. Eighth nerve is totally absent, or cochlea is totally absent. In that case, there is no further management possible. In that case, sign language can be done. And in case if there is a possibility that the child is getting cochlear implant, which is very frequently available in most of the district places even nowadays, and even at higher centers, which is very well established. And there are different government schemes also going on, like Rashtriya Bal Swasthya Karyakram and ADIP scheme. And even there are different donors like Ratan Tata Trust and so many other trusts. So it is very easy for a child to go for cochlear implant, which really changed their life. And in my small experience of 21 years, I've seen babies growing into getting admissions in medical colleges. And that is possible only because of early identification and management. And hats off to the community of pediatricians who have helped these children to achieve this. One last point I would like to just put here. Like many a times, audiological evaluations are done by underqualified individuals, and that makes impression of the report as well as misdiagnosis or means I've seen children coming after 2-3 years of different testing, and all sorts of diagnoses are done of the same child, right from normal hearing to profound hearing loss. So we should I will request all the pediatricians to choose a good audiologist in your area to refer patient and refer these young souls and develop their further speech language. And in India, audiology and speech language pathology is a dual qualification that's kind of boon to our community, and in that way we can help these children better. So with all these points, I would like to thank all the respected members of Maharashtra IAP and all the dignitaries and respected members. Thank you.
Thank you so much, sir, for guiding us and giving your valuable opinion. And all the points discussed will be well taken by us. Now I request our Maha-IAP President, Dr. Ramakant Patil, sir, to comment on both the research papers. Over to you, sir.
Thank you, Dr. Swati. The comments were so elaborate by both Dr. N.K. Subramaniam and even Rahul. And the paper itself and the comments had decoded many misgivings or even doubts were cleared. And it was a wonderful decoding by Dr. Subbu about the scoring system, because many times we clinicians very rarely use scoring system. But the most valid point which was made that whenever we are not sure, microbiological diagnosis is not there, and can we wait for starting the treatment? That definitely had. But with the advent of newer and newer better techniques, probably this scoring system, but till that time, it definitely has got some role in management of the patients. I will like to congratulate both the presenters for selecting the excellent topic. And even if it is late, it was so interesting, 1.5 hours. Everybody were glued to this thing. And even still at 10:30, 86 people are there listening to Journal Journey. It speaks volumes about the popularity and interest of we pediatrician in listening newer things. Over to you, Swati.
Thank you so much, sir. Now I request Dr. Jay Bhandarkar to take up some questions if there are any in the chat box. At least I don't see any, but if anybody has some questions, we can take them, 1 or 2 maybe.
I think it is 10:30.
I know.
Okay, madam.
Only,
So,
I think the question they have got is what is the time now?
Swati, one comment I would like to make, if you permit. Swati Jitra.
Yes,
yes,
sir.
sir. Yes, sir.
Firstly, I would like to congratulate IAP, Maha and Raigad for taking very wonderful, very touching subject, which is day to day. I think we have got expert like Subramaniam sir. I cannot talk after it all. He will get 5 marks, 5 out of 5. The thing which touched my this thing was clinical based scoring to diagnose TBM. Sir, Surano sir, and also the Anup Moruskar. Nowadays, we are not seeing much of the TBM in our practice, private and in medical college. So, to whom to give credit? Is it to basic vaccination? Is it to hygiene? Is it to overall impression nutrition? Or is it to anything else? That one word I would like to know. Because, see, definitely pediatric care has been taken care by not only pediatrician but GP also, because we cannot cater to 100% population of children newborn. So one question is, I'm not sure whether Subramaniam sir, you see many cases of TBM. I'm not seeing since like 10 years in even the medical college in Nagpur and in private practice, we don't see single one. So number one. Secondly, to Priyanka Parikh, the hearing assessment, infant and child, definitely. So your take-home message, where I was having a child today, 10 month old, today only I had done, he was not able to listen. I was 100% sure that he will be hearing issue. But I'm surprised when we did Bera said no, but even I wanted to rule out autism, because there are two things when child doesn't see communication. One is, unless you rule out hearing, you cannot diagnose. Autism is very early at 10 month old, unless we got. So how do we go? So first to Subramaniam sir, and then to Parik.
Sir, I would love to comment on the second question, although
Yes.
Dr. Priyanka wouldn't agree with me. But testing of hearing is like testing a hardware, and looking for autism is like testing a software. Suppose your mobile or computer goes off, first thing is that you check the hardware first, whether all the plugs and points are okay, and then only you comment on the software. I think that would be the easiest way that Priyanka could defend. I can see smile on her face. But coming to your first question on tuberculosis, definitely we are seeing reduction of tubercular meningitis and disseminated tuberculosis. But the experience for us in infectious diseases has been so far like this. There has been decrease in epidemiology, and there is re-emerging diseases that do come, that we have seen in many of the infections. Forgotten diseases have come back. Now, what is the guarantee that the tuberculosis won't come back? But Bodhankar sir, you would agree with me that only way the tuberculosis can come back if there is a pandemicity of HIV. That's when you can get disseminated infections. I do not know. I don't have the knowledge to comment on whether in a HIV patient the scoring helps or not. There is no evidence for me to speak on that and clinical features of tuberculosis in a patient with coexisting HIV when there is a disseminated disease. In that case, it is not infancy, it could be any age, even adults. One can get disseminated tuberculosis due to immunodeficiencies and HIVs. That's a gray area. But however, even in the West, my brother is working in Michigan University and he's head of the Department of Radiologist. He was telling me that there is re-emergence of infections even there, who have forgotten and they have all deleted many pages of textbooks of infectious diseases. They're all reopening. But when the infection re-emerges, it is much more complex than the previous one. Already tuberculosis is complex. I don't know which MD student would read the next clinical features of complicated tuberculosis should come back. And I think that would open another MD in mycobacteriology, because it is impossible to study that particular topic in any one of the MDs with 3 or 6 months of training. It would open MD microbiology, which is the need of the hour as far as our country is considered. So we should have MD neonatology, not DM neonatology, because it's too much for 6 years. We should have MD pediatrics and MD in mycobacteriology, and I think, or infectious diseases for that matter, given the burden of the disease with us. But only thing is that as educationists, we are cut copying and pasting from the West, and therefore we have to wait for some time.
Yes.
So, Dr. Bodhankar, I would just like to add, Dr. Subramaniam, thank you for giving the simile. It was, you sort of mentioned it in one sentence, hardware and software. So that was really nice. Look, when we're looking at a 9-month-old child, so one would really not rush into any kind of a diagnosis, even if you're looking at autism. So what we call like early signs or the early red flags. And again, as we mentioned about risk factors, we need to see that are there any risk factors more for hearing loss, family history of CMV. Then again, we still need to do monitoring still over a period of time, because it can still emerge as time evolves. Similar with autism. So we may see one sign as non-response to name, but as the child grows older, we still have to keep monitoring the developmental milestones and looking at other red flags. But what is important is to start with early intervention. So say at this point, BERA is normal, but we are still seeing some delays. It is important to start with the early interventions, with the speech stimulation, language stimulation, as well as, the other aspects of development. So we should not withhold interventions till we are waiting to reach a diagnosis. That's the most important take home.
Thank you, Priyanka. One word. When should I again reassess after having Bera? This thing.
Yeah. So again, we don't have published guidelines, but when we are looking at that paper and those tables which we had put up on the slide, those tables are giving the recommended age for diagnostic follow-ups, the first diagnostic follow-up, as well as the monitoring frequency. So say if it's a child who's at a risk of CMV, the monitoring is every 12 monthly till 3 years of age, or till school age. In fact, say for ECMO also it is the same, and for the other conditions it is as per caregiver concerns or clinicians concerns. So again, that still gives a rough kind of a guideline of how frequently to monitor. And what is also important is like the real-time assessment, which we said, monitoring of the milestones. So the proof is in the pudding, the eating proof of the pudding. So if the milestones are developing well, we know that yes, the hearing seems to be fine. So it is not just going by the book, but also monitoring the child's development.
Thank you.
Bodhankar sir, permit me for one question to Priyanka. Priyanka, the newborns with bilirubin encephalopathy on follow-up, what is the frequency of Bera on the same note?
Yes. So the first follow-up, I'll just share my slide. Can you see?
I think I missed
So
it,
here,
sorry.
hyperbilirubinemia
By 9 months.
with by 9 months, and monitoring frequencies as per concerns.
Sorry, I
and
missed it.
so here it has, the table mentions for different conditions as per the etiology. I've split it up into 2 slides, but it gives details of, for the different conditions in NICU or trauma or family history or genetic conditions. So it gives the recommended age as well as the monitoring frequency.
Okay, thank you.
Thank you. Well done. Both the speakers, both the experts. Give a big round of applause, all of us.
Yeah, ma'am, usually
Thank you
when
very
they come for vaccination, at that time, with each visit, we do assess.
Yes. So that's what we should take that opportunity. So the frequency of visits are much more in the initial months. So to review whether the screening has been done, to review whether there are risk factors which we need to, whether we need to do something. And even in an older child, just to go back to our history taking, like how we do. So it is important to just go over a quick risk factor history taking, so we have not missed out. Sometimes a child comes for the first time to us, or to a general pediatrician at the age 7 or 8, and you have never seen that child before, or a child who has come from a different city. The first time meeting with the child should be like our undergraduate, postgraduate history taking, where we are looking at the full history from birth to later childhood.
Last comment, madam.
Perfect.
Dr. Chitra and Swati Subramaniam sir, you must be aware that recently the Goat and Child Monitoring chapter of IIP has formulated the IIP immunization chart along with age, then developmental milestone, and then the vaccine. So I am using that since last 1 year.
Yes, sir.
I think we must promote that. That will give early indication and early intervention.
Yeah.
Thank you.
It
Only
is in
one
pictures.
question, permit me, Chitra madam.
Yeah.
Now for Priyanka, now I am asking this question not as a pediatrician but as a medical superintendent. Okay. Please tell me whether I am the medical superintendent in a teaching hospital here at PES. I wanted to know, does the reimbursement is more from the Smile Train or from Ayushman Bharat as far as money reward? Is it more in dollars or rupees as far as cochlear implant is concerned? Where should I put
This
my...
is something that I personally am not so aware of, because
Okay,
I
fine.
am not directly
The second
involved
question
with
is,
the
does cochlear
cochlear
implantation requires somebody audiologist with BSc or MSc? I have got both the CVs with me. Whom should I take?
I think Dr. Rahul might be a
Rahul
better
sir can answer
person
better,
to
sir. Rahul
answer.
Sir, please
Yes.
tell me, sir. I'm in
Yeah.
real need actually, or if you can share your number, I'll speak to you later.
I
Yes,
will
sir.
send. I will send.
Sir, regarding cochlear implants, Smile Train doesn't fund, like, as far as my knowledge, and government schemes like Rashtriya Bal Swasthya Karyakram (RBSK), they fund up to 2 years or 3 years or less of age, and ADIP, that is central government scheme,
5 years.
which funds for cochlear implant up to 5 years of age, and postlinguals are also funded in that. As far as my knowledge, it is up to 10 or 15 years, but it should be postlingual, and it has to be documented postlingual. Uh, Otherwise, Smile Train funds only for cleft lip and
Cleft lip
palate
and palate, not
surgery
for.
and further management.
Very
Is there
good.
any dollars
And
for cochlear implants? No, only rupees.
Rupees.
yeah, rupees are enough here because we get basic cochlear implant in that, and in some programs there are auditory verbal therapies also taken care, which are more like elaborated kind of funding, which is most important part. Only after cochlear implant there has to be auditory verbal therapy, which has to be done by qualified people who are trained in auditory verbal therapy approach, uh, and mostly graduate or postgraduate are required for cochlear implant program, because it's little bit detailed and further kind of intervention. So the team has to be established. Nowadays, lots of uh, otolaryngologists or otologists are doing cochlear implant, but there should be a team. If the team exists and if it is active, and then only we can produce results. So we are fortunate to associate with great people like Dr. Milind Kirtane and all the big hospitals in Mumbai and Pune. And recently, new centers are coming up. They are also trying to do the best of their job. Uh, but it has to be chosen properly because many
Thank you.
new centers are coming up without teams. So just try to add
I'll
something.
catch you up sometime later, not on Zoom, sir. So
Sure, sir.
Amol has shared your number to me. Thank you, Amol. I
Thank
will
you.
just follow it up.
Yeah, good information, Rahul. I think you share all these things on. I will request Chitra, Swati, and Amol Power and to circulate it. Very good age wise and donation wise. How much they can give. Very good. Only one last question to all experts. What is the earliest age where cochlear implant? 6 months, 9 months, 1 year. Once you
Uh,
diagnose.
it's 9 months as far as my knowledge,
Okay.
and 7 kg 7 months worldwide. That's what is usually
Nine
given.
years. Hemoglobin also here. Okay. Thank you.
But one would also start with some hearing aids prior to the implants, right?
Yes, yes.
When
We
you
have to go
diagnose. So
by Cochlear Implant Group of India protocol. We follow first hearing aid fitting, then training with hearing aid. The child has to be trained for at least 6 weeks, 4 to 6 weeks, depending on their intellectual development. And then there has to be some awareness given. Then we do their aided audiometry, that is the benefit of hearing aid. If that is not so, then further cochlear implant.
Dr.
Excellent. Thank
Swati?
you.
Yeah.
Yeah.
Thank you, sir, for the elaborate discussion today. Now, before I invite Raigad IIP Secretary, Dr. Ajay Kohli, sir, I sincerely thank guest of honor, Dr. Uday Bodhankar, sir, our
Yeah.
experts, Dr. Subramanian, sir, Dr. Rahul Vaidya, sir, our excellent speakers for today, Dr. Anup and Dr. Priyanka, for making this journal journey a very successful one by sharing their invaluable insights. And my deepest gratitude to dear Chitra madam for her consistent efforts towards this journal journey. And last but not the least, thank you all the viewers for sparing their valuable time and attention. And I wish each one of you a happy and healthy Diwali. And I look forward to see you all in the month of December again. Thank you so much. And now I request Dr. Ajay Kohli sir to give formal vote of thanks.
I think you have given a vote of thanks. We request Amol Pawar sir for further announcement if somebody is ready for 1st December. Okay. Okay. Yeah. It will be decided later on.
As a only a delegate, he is
Yes.
no officer for till 5th of November. So do not ask him.
Okay. Okay, sir. Okay. So I'm very much thankful for such a elaborative session, and it keeps on interest till 11 p.m. Thank you, the speakers, that is Power of Subbu sir, I believe. Thank you very much and good night.
Thank you. Thank you all. It was lovely
Thank you.
interacting with all.